Well, hello, everyone. I want to welcome you today to this webinar hosted by the Schaeffer Center for Health Policy and Economics. My name is Dana Goldman. I'm the director of the center. And today's topic is the future of American healthcare, although, as I think the Q&A will suggest, really we might want to say the future of American health. Before introducing Dr. Fineberg, I just want to remind people that you can submit questions at any time using the Q&A feature, which is at the bottom of the screen. I'm very pleased to have today's conversation with one of the nation's leading healthcare authorities and thinkers, Dr. Harvey Fineberg. Dr. Fineberg is president of the Gordon and Betty Moore Foundation. He's chair of the Standing Committee on Emerging Disease Threats and 21st Century Health Threats of the National Academy of Sciences, Engineering, and Medicine. He has decades of experience that spans vaccine safety to understanding the societal risks to AIDS prevention. He has authored and edited books and journal articles on these topics and many others. Among them, he's the co-author of The Epidemic That Never Was, an analysis of the controversial U.S. immunization program against swine flu in 1976. Welcome, Dr. Fineberg.
Dana, it's a pleasure to be with you, with the Schaeffer Center family. I really look forward to our conversation. I would like to note as we start, this is really an auspicious day because this is actually the birthday of the benefactor and founder of the Schaeffer Center, Leonard D. Schaeffer. So we ought to take a moment to recognize and celebrate that. Now, it is true his mother did all the work and he just showed up, and he's been showing up ever since, eminently successfully. And we're all in his debt for his generosity and vision in creating the center. And it's such a treat for me to be with you.
I just got a Q&A for him and saying that I was fired, so. Yes, happy birthday, Leonard, and this is part of your birthday present. So, but I want to start with obviously talking about coronavirus. And about a decade ago, you chaired a WHO committee which reviewed our public health response to H1N1 influenza. And I want to ask you about that experience, but as context for the audience, in February of 2009, H1N1 appeared in Mexico. And by the next month, we started to see cases appearing in California. By June, it was a full-fledged pandemic in at least 73 countries. And interestingly, the case fatality rate in Mexico was about 6.5%, which is similar to COVID-19 in Wuhan. But in the H1N1 case, it took about 32 days to come up with a vaccine, and WHO was able to distribute antiviral treatments to about 72 countries within months. And obviously we have no vaccine for COVID-19, although some treatments are starting to emerge. So my question is about the policy response, and it's a counterfactual. Would the course of H1N1 have been any different if we didn't have a vaccine? Or in other words, is pandemic spread inevitable in a modern global economy?
And that's a really critical question. The H1N1 experience of 2009 was definitely helped by the presence of a vaccine. Influenza vaccines date back decades and have been utilized on an annual basis as well as in a pandemic year. So vaccine is a very useful tool. In the case of influenza, interestingly, in a typical year, a vaccine may be only about 50 to 60% effective overall. That is to say, if you have a population in which 1,000 people unvaccinated would get the infection, with the vaccine, only about 500 of them would get the infection. That's not zero, but it's better than 1,000 becoming infected. So vaccine really helps in the case of influenza. When it comes to lessons with respect to coronavirus, maybe the experience of SARS and MERS, which were also coronavirus outbreaks, could be even more telling for us than the experiences of influenza. It is a respiratory virus as well, but of course, a very different type of virus. And one of the lessons from the SARS and MERS experiences, which may be relevant to us today, is about the duration of immunity following infection. How long do the antibodies persist? And in the cases of these other COVID outbreaks, it's not in years, it's more typically in months that the antibody levels persist. Now, having said that, a vaccine that is effective on some cases in certain other diseases can be even better than the natural infection at preventing a recurrent infection. So the bottom line with a COVID vaccine and lessons from the past, I think is really, we just have to see. We have to test, we have to examine, we have to do what we need to do to follow up on those patients and learn about the safety and efficacy of the vaccine.
So just following up on that, so if, I know you'd prefer I do SARS and MERS, but if we have only 50% efficacy for a coronavirus vaccine, are people going to accept that? And in addition, there's already some fear, and we have an anti-vaxxer movement in the United States and to some extent in the UK. Are people going to be willing to get vaccinated with a 50% efficacy rate? And if someone gets vaccinated and then gets COVID, is that going to jeopardize our entire immunization strategy in the United States?
You're hitting on a really important set of issues here that all circle around the core question of vaccine hesitancy or resistance to immunization. And, it wouldn't just be that the vaccine were 50% effective. Suppose it were 90% effective. You could still have some people say, no, this is a new product. This is a new vaccine. I don't want to be first in line. I want to make sure that it's really, really safe. Let others go first. And then you have the more extreme anti-vaxxers who just believe that this is all part of either a hoax or a conspiracy to get them to use a vaccine that will harm them or hurt their families or otherwise be deleterious to their well-being. And there is a real worry about that movement, been fed by a lot of false claims about risks of other vaccines, and it is a genuine concern. In 2019, the US actually had a major measles outbreak in New York because of a sufficient number of people who resisted the idea of immunizing their children. And this actually gets to a very core problem for public health and prevention, Dana, which is this: when it works, it's invisible. So people lose sight of the reality of the dangers of these diseases, which are no longer occurring because of previous immunization successes. So how do we deal with it? Number one, we have to do honest assessments of the value of the vaccine, its effectiveness and its risk. Number two, we have to communicate honestly, clearly, and consistently about the vaccine and what it does and what it may not do, both what we already know and what remain to be uncertainties. Third, we have to be honest with the public about the level of risk that may still pertain at a very rare level. For example, if you test 30,000 people, you can't tell if there's an effect that will occur 1 in every 300 or 400,000. So we have to be clear about that. And then we finally have to genuinely monitor the effects of the vaccine in a post-market surveillance effort to be sure that we track its continued effectiveness and safety profile as it's being used. I think we will have a strategy that will first look to immunizing the highest risk individuals in the healthcare workforce, in the service industries, and the emergency response areas, those who face the greatest risk from the natural infection, and for whom the uncertainty of risk of vaccine is less of a deterrent to needing to be protected against the disease. And so if we do it smartly, if we do it honestly, if we're lucky enough to have a vaccine that is 60 or more % effective, I think we can overcome the resistance which is there, at least to a sufficient degree to protect the health of the population as a whole.
And you talked about how we allocate it by risk type. What about globally? What is our responsibility? Let's say it's developed in the United States. What's our global responsibility?
This is a really deep and ethical problem. We raised it profoundly in that 2009 review for the World Health Organization, looking at the H1N1 experience of that year. It is a currently unsolved problem. Frankly, it's not a problem that you can successfully cope with in the midst of a pandemic. It's something you have to anticipate, lay out the ground rules, have a common understanding. But for example, having every manufactured pool of vaccine divert a certain fraction to a global redistribution pool is a kind of idea that I think would have some ethical grounding and real merit in enabling a global response wherever a future pandemic may occur. And keep in mind, the world needs continued cooperation from every country, because we also need to be able to find the viruses when they come out of the animal environment into the human environment, and be able to detect and manage them rapidly. And that's going to depend on cooperation of every country all throughout this process. So vaccine distribution is going to be a real ethical and public health challenge.
So I'll put you on the spot a little bit, which is, suppose the vaccine gets developed in China, where our president has called it the Chinese virus. What fraction of Americans do you think would be willing to take that Chinese vaccine? And do you think the Chinese will make it available under the same sorts of rules that you've just articulated if we developed it in America?
That's a really speculative hypothetical. You know, China now is actually testing 3 different vaccines in their clinical trials. There's another one in the UK and in Europe, and there's of course the US testing of Moderna. So any one of these 5 may prove to be a superior product in terms of its efficacy, safety profile. There may be, if we're lucky, 4 or 5 that actually work sufficiently. The more vaccines that are successful and could be manufactured and distributed in different parts of the world under licensing authorization agreements, for example, those would all be to the benefit of every country, whether you happen to be the lucky one where the vaccine was first developed or you're more in the market to buy it from others. So whether it comes out of Europe or comes out of China or comes out of the US, this global distribution is going to be a major, major challenge.
Well, I think we can all agree that if you were put in charge of distributing this, we might feel a lot more confident than some of the players right now. But I want to move on. I mentioned that this is on the future of healthcare, but I was struck by something you wrote after the passage of the ACA in the New England Journal of Medicine, where you noted this is not, the ACA was not really, or it shouldn't have been really about healthcare coverage. It was really about population health. And at that time, we thought there was a prevention fund, there was all sorts of funding for CMMI demonstrations. And I think we had a lot of optimism that maybe we could make progress on population health. It hasn't quite worked out that way. Health disparities are greater than ever, exacerbated by the recent crisis. And the prevention fund never really materialized because of infighting, I think, within the legislative branch and with the president. The current president came in saying he was going to get rid of the ACA, but not offering an alternative. And I wanted to ask you, how do we move the needle on population health?
We have to learn the lesson that we get repeatedly shown, but don't fully absorb once it's passed. Namely, when these crises occur, if we haven't laid the groundwork with a public health infrastructure, if we haven't established a basis of healthcare coverage that is in a way immune, if I may use that word, from the setbacks in the economy, if we haven't provided the training and personnel that are needed to do the detection, the contact tracing, the follow-up, the quarantine, the isolation, the data management that are all required to cope with a public health threat, we're going to suffer. And frankly, we are suffering. So if the aftermath to COVID leaves any positive lesson for public health, it ideally will include a level of support for core public health functions at the local level, at the state level, and at our national government level, so that we don't find ourselves repeatedly facing the crises without the available equipment, people, and strategies that can help us get through them much more safely and with much fewer loss of life and with shortened setbacks for the economy and all the rest.
Well, I think, another version of this is the Defense Department budget is something like $650 billion. Take out some wars that we're fighting, and you're talking about $500 billion that we're spending to save American lives. And meanwhile, we have a virus that's killing 150,000 Americans. And we have a CDC budget that is a fraction of what the Defense Department budget is. And yet more Americans are dying. We know it's triple the deaths in Vietnam War and the like. And so if you think of this as a national security issue, we're completely underinvesting in public health by, hundreds of billions of dollars. Is that what's needed here?
I do think the framing of national security is a very apt way to think about this challenge, because we are susceptible in our lives to threats from many sources. Yes, there are literal enemies and potential military interventions that are a direct and indirect threat to America and to our well-being. Yes, there are terrorists who are willing to sacrifice their own lives in order to undermine our society and to cost our lives. And yes, there are natural enemies, including these viruses, which pose periodic, dramatic threats to our health and well-being. So a security framing that looked at the threats to the well-being of Americans and understood it in the comprehensive way that you're describing would definitely advantage us in making smarter allocation decisions about where do we spend what resources to increase the security for American families. And that's the way to think about it. And if you begin to approach it that way, it would undoubtedly lead to a much more substantial allocation to the public health infrastructure, to the health security of Americans, at the same time as we protect against other threats.
I thought it was kind of ironic that if it turned out that this was a bioweapon manufactured in a lab, there would actually be more resources available to fight it because it would be viewed as an enemy, and we'd have access to the resources in the Defense Department budget. Whereas if we find out it's natural, well, then it's someone else's problem. So,
nature can be the most terrifying terrorist of all. And I do think that the notion that we can mobilize some resources and not others in facing this kind of national threat is just a misguided expression of policy. And it's one of the things which I hope we can gain in lesson from this experience and strengthen our hand when the next outbreak occurs. And there will be future emerging infections, hopefully not with the ferocity and characteristics of the COVID-19 outbreak, but we have to be prepared.
Right. Well, I think that was an excellent summary. I'd like to move on a bit and talk about the future of healthcare. And I'd like to speak in particular about something that people have taken advantage of maybe in the audience, which is telemedicine and digital health. And one of the, it took federal investment in the HITECH Act just prior to the ACA to start to get us to think about how we do electronic medical records. In this case, there were some regulations at CMS in the Medicare program that allowed for reimbursement of telemedicine visits that have allowed for people to continue care, although there are access issues. Could you talk a little bit about the future of telemedicine and how the public and private interaction will either affect it or allow it to accelerate or block it?
This is really another fundamental question, Dana, that you put your finger on. You know, the forced physical separation that we're all experiencing in the face of COVID has affected our lives, our work, our schools, and indeed our healthcare and the way we interact with our health providers. We're all learning lessons as we're going. We're learning about some of the potentials of this remote interaction in work or learning or clinical medicine, at the same time as we're uncovering some of the shortcomings and where the boundaries are, where it can and cannot actually accomplish the job. In the case of telemedicine, I think one of the lasting effects of the COVID experience will be a greater familiarity, greater reliance, and a greater role for telemedicine in clinical care. I think it's going to go along with other technological developments which are beginning and coming even more forcefully along the way in terms of home-based monitoring, in terms of even putting test equipment of different kinds on our wrists, on our clothing, in the way we just go about our daily lives. It will be medical monitoring without necessarily thinking that we're now doing a test. We're simply living, and we're nevertheless getting valuable personal information that can be helpful to our clinicians and to ourselves in managing and monitoring our health. When you combine that with a possible future of 5G Wi-Fi networking, and ideally a commitment to do for all of America in the 21st century what our predecessors did in the rural electrification of the 20th century, namely bring electricity to every home in America. If we bring 5G to every home in America, every provider will have that level of clarity, access, bandwidth to be able to discern and to interact in ways with patients and data systems that right now just are technically beyond us. So this is an area where I see a tremendous future and really important lessons coming out of COVID for the ways we can work more successfully in medical care, meaning more efficiently, with great interaction and high levels of quality and satisfaction compared to the traditional way of doing things.
Right. I think you're right. One of the interesting things is the role that the interesting and unanswered questions is the role that these technologies will play in either compressing or exacerbating health disparities. If you rewind the clock, so you take diabetes, for example, we've done some work at the Schaeffer Center which demonstrated that the introduction of home glucose monitoring devices, you know, finger pricks, as you know, and then checking your blood sugar, exacerbated the health disparities because certain households had better access to this technology. But that's not always the story. If you look at the introduction of antihypertensives, for example, they were widely available to everyone, and actually elderly African-American males were more likely to get it. And so that actually compressed the disparities. So are you worried that this 5G technology might work to make it more difficult in that regard?
It's a worry. It's the reason why I coupled my comments with this notion of a national commitment to bring 5G to everyone.
Right.
You know, immunization we were talking about before is another great example in healthcare of a universal strategy that benefits everyone. It doesn't matter how wealthy or poor, where you live. If you can get immunized against threatening infections, you can be greatly advantaged. So the trick is to introduce these technologies in ways that reduce disparities, that level the playing field, that make care more widely and readily and equally accessible. And that's where I do think it is possible with telemedicine to serve that role if we have that infrastructure in place. And that should be our goal.
So if we had universal coverage with access to prevention, and part of this is prevention, maybe primary or secondary, you would support that type of policy. Certainly it would move, or you would argue it would move us closer to the goal of better population health and reducing disparities.
It certainly would. You know, you put your finger on the goal properly earlier when you talked about the health of the population, because ultimately the reason we care about things like telemedicine, or we care about health insurance, or we care about having a hospital available, all of that is directed and ultimately aimed at achieving health, maintaining our health, improving our health to the extent possible. And that is really the goal we should keep our eye on.
Okay, we're about 30 minutes in. I want to answer some of the questions we have for you. In your opinion, what are the most important public and private policy changes that could be implemented to slow the rising cost of healthcare services?
This is about the cost of healthcare services and the
Yeah.
policies that could be implemented. Well, number one, of course, on many economists' lists, and that I think is very important, is the movement away from the incentive structure of fee-for-service toward the models that rely much more on prepayment and benefit from keeping a patient healthy and minimizing the excess and unnecessary services, because that would be a first means of definitely changing the incentive structure toward reducing the drive to increasing costs. Secondly, I would like to see every hospital adopt a policy of smoothing the flow of patients coming in under elective procedures. This is an incredibly powerful way to reduce the apparent demand for new beds, new emergency services and departments, because if you look at a hospital as what it is, which is a huge capital investment, the greater utilization you can make through the 24-hour day and 7-day week of that high capital investment, the greater your ability will be to reduce the demand for increased investment in the most expensive part of our health system. So a second strong recommendation for me would be implementable and doable literally by every hospital and hospital system in its own domain. Third, which you wouldn't be surprised coming from me, the best way to reduce cost is to eliminate the need for the service. And that means prevention.
Right.
And that gets us back to what we were talking about before. The biggest challenges today, the chronic disease burden in the United States, year in and year out, apart from these really incredible bursts of demand around an infection like COVID. But the core challenges of reducing our burden of cancer, of heart disease, of diabetes, the things that cost our lives and treasure really would be greatly benefited from deeper investment in education, lifestyle, behavioral adaptation. We could learn something surely from genetic details of higher or lower risk, but we already know enough about what creates risk for heart disease and cancer, and why we still have smoking, and why we are not doing a better job at eliminating the food deserts and making nutritious foods available more widely in our country, why we aren't reinforcing the education about daily exercise and taking care of oneself. These are things which, as a nation, if we manage to do, we would shift the curve of a burden of the onset of these diseases in ways that would not only protect our health, but reduce the cost of care. So we could go on, Dana, but that's three.
No, those are very useful, and actually, it gets at one of my pet peeves is that if I develop a drug that treats diabetes, I can get it covered by insurance. But if I figure out how to get people who are at risk for diabetes to go for an hour-long walk every day, I can't get that covered by insurance, and there's no intellectual property. And that's a very perverse system in my view, because we'd rather prevent it than treat it, and yet the playing field is completely tilted in the opposite direction. So
very true.
Yeah. I also figured out that we should have, I decided that we should, and others have heard me say this, that we should have coin-operated elevators to encourage people to walk. And I was told that that was not ADA compliant. So
maybe it depends on how high you put the coin insert.
Yeah.
But I would tell you that convenience, just to extend that point, making it easy to do the right thing is really an important principle for design of buildings, for design of our cities. Make it easy for people to take that walk. Make it convenient to choose the right food. I had a very interesting experience when I visited one of the Google headquarter buildings in the
Googleplex.
Yeah, the Bay Area, and noticed that they, of course, had abundant food in their cafeterias. In fact, tremendous amounts of delicious and wonderful food. And Eric Schmidt was famous for saying, why should I, when he was asked, why do you give the food away for free to your employees? He said, why should I pay them to pay me? So that was a great comment. But here's the point. They also had vending machines. You could buy snacks, but the pricing of the snacks had nothing to do with like their wholesale price. It had all to do with how good or bad the snack was for you.
Right.
So you had to pay a lot for a lousy piece of hyper sweetened junk, but you could get a piece of fruit really easily. Anyway, I thought that was an interesting pricing mechanism, and it goes along with this idea: make it easy, make it cheap, make it convenient to do the right thing.
Well, as an economist, you won't get an argument that price matters. So,
Yeah.
okay, I want to get to some more questions. Assuming Joe Biden gets elected, although the questioner did not make that assumption, what would you change via regulation during the first 100 days? What would you advise?
Via regulation.
Yeah.
Now, are we limiting ourselves to health and public
No,
health?
I think you can, you have a wide, and I'm going to come back to your wide experience.
This is so big. I think just speaking personally, one of the program areas that's so important to us at the Gordon and Betty Moore Foundation is environmental conservation. We work on this all over the world, but we also work on it and care about it in the United States. And what we need to recognize is that the long-term sustainability and resilience of our economy is intimately connected with the way in which we treat our environment, and which, by the way, is also connected to the likelihood of emergence of infectious diseases. These changes in our way of living and interaction with our environment are all connected. And so the first big area that I would look for regulatory adjustment would be in the area of the environment. Yeah. When it comes to healthcare, again, speaking personally, I'm not saying whether you abandon or reinforce what's called Obamacare. I care about coverage and promotion of health. So I would be introducing ways that we can improve the coverage of Americans. Hard to do that all by regulation, except there are some judgments about requirements on coverage that you could relax by regulation, but this would really fundamentally require legislation as well. So it would also be some regulatory adjustment and legislative proposals.
Thank you. And I want to, people may not, I'm glad you brought up environmental issues, because I don't think people fully realize how committed you have been to evidence-based science your entire career and the importance of that. And there's a sense that science, for whatever reason, has become less important now, or it's harder to translate it. People are more skeptical towards scientists. And are you worried about this trend? Maybe social media has made this worse. Are you worried about this trend? And do you see a better way for science to communicate to policy audiences as well as lay audiences?
Dana, there's always been this kind of dance among the scientific community, the policymaker community, and the media as mediators to the public and the public understanding. And the way and role of science in aiding decision-making, in informing the public through the media and directly, is really a fundamental task for science in society today more than ever. And I think that the ways in which some of our scientific institutions, such as the Centers for Disease Control and Prevention, have been pushed, if you will, to the sideline. For example, being bypassed in a latest data collection, which may be based on good motive, but still sidelines a very critical public health agency rather than strengthening it. And the ways in which senior figures, including our president and others, can espouse ideas that are not grounded in science, in fact, contradicted by science, where conviction outpaces evidence, which, by the way, is not a condition limited to political figures. Scientists can also have conviction outpace the evidence, and we have to be self-reflective and aware of that as well. But your point about learning from evidence, if you don't learn from evidence, what is the alternative?
Mhm. Yeah, no, I think that's right. But it's also the case that people aren't reading journals anymore. They're not even reading traditional media. And it is very hard. I've actually, one of the things I saw, this happened with the ACA and also with COVID-19. You see that journalists at the start, they don't know a lot about the subject. They didn't understand adverse selection and insurance markets. But as you report over the year, you saw that the stories and the knowledge base got better. And the same is true with coronavirus. I mean, the early stories were very speculative, but now they have a pretty good handle. And actually the reporting with the epidemiology and the modeling has become quite sophisticated. But most Americans, I think, are not even getting their information from those sources. And maybe it's hard for our audience to believe because they consume traditional media, but that is not where the debate is playing out. And I assume the president tapped into that successfully in an election campaign.
It's a challenge really that permeates us today, our society. It's not limited to health or COVID or to politics or any specific field. You know, the reality 50 years ago was Americans all watch one of three networks. That was it. You had the three majors, and you watched the evening news on one or another of those. And the most trusted figure in America at the time was Walter Cronkite, who was legendary as a newscaster. And everybody had their favorite, but that's what we all shared. Now, with the multiplicity of channels, with the separation of people into smaller and smaller groups of shared interests, where there's a mutually reinforcing message which may be out of kilter with scientific evidence, this is a huge challenge. And I think the solution to it is not trying to restrict people or channel what is available, but rather championing and celebrating those legitimate channels that can convey reliable, consistent, clear messages to the public, and that over time people come to trust that the interest expressed is a public interest and not an agenda that's personal, political, self-interested, or otherwise other than their interests. So that's the challenge, and we haven't solved it.
Well, I think that's a fantastic message for those of us at the Schaeffer Center. It's what we're trying to do. And we appreciate your time, Dr. Fineberg. It's been a fascinating discussion, and we really appreciate it. And I don't know if you have any last words that you'd like to share with the audience before we end.
Well, thank you, Dana. I think that this lesson of the COVID experience is one that leads each of us to reflect for ourselves how it affects our lives, how it affects our thinking, how it affects our desires for the future, for our nation, indeed for the world. The great thing about the USC Schaeffer Center is its ability to try to bring evidence to bear on these critical questions that affect our health, especially, and our economic well-being. And I just want to thank you, Dana, for your leadership and the colleagues that you have assembled together in bringing forward so many important messages for all of our benefit. So thanks for the chance to be with you today, and good luck and continued great work.
You're very kind. Thank you, and take care, audience, and be safe. Bye, everyone.
Bye-bye.